meaning what the likely cause is. Okay? We'll talk about how to treat it in coexisting next semester. Okay? Okay, abnormalities of cardiac dysrhythmias. Basically, anytime you have any form of dysrhythmia, the first thing that should top in your head thinking is what's happening to oxygen delivery. Is there some issue with ischemia of the ventricle? Okay? So anything that causes decreased oxygen to the myocardium, such as arterial hypoxemia, myocardial ischemia, or increased workload, so it leads to increased myocardial fiber stretch, hypertension, or sympathetic discharge from intubation, could all induce cardiac dysrhythmias. The most important cardiac dysrhythmia that we encounter in anesthesia is sinus tachycardia, is the most common. Okay, the next most common is sinus bradycardia. Okay? Those are easily treatable, usually most of the time. Electrolyte disturbances are also important. You have to look at hypokalemia or hyperkalemia. Potassium is a critical component. And the other one that you cannot stop thinking about is magnesium. Without adequate levels of magnesium, you cannot replete potassium, so you want to keep that in mind. Okay? Acid-base disturbances can also induce cardiac dysrhythmias because what they end up doing is alterations in potassium. Okay? Here's a clinical example. Okay? I had a patient the other day. I was working with a student. The patient had a history of a lot of arrhythmias, and the student was kind of nervous, so we gave the induction. And as soon as we started giving the induction, the student started ventilating. All of a sudden, the person had big-time PVCs and was having all sorts of kind of conduction delays. And the student was very worried and said, oh, we're going to be in a lot of trouble here. I said, no, how about stop ventilating? And he looks at me like, what? Stop ventilating. Okay? He stopped ventilating. What he was doing was he was doing this. Okay? And every time the person's arrhythmia got worse, he got more vigorous with the ventilation. Okay? So if you hyperventilate somebody, what happens to potassium? It drops. Okay? It's a treatment of hyperkalemia is hyperventilation. So if you have somebody who's on the borderline to say 3.4, and also you start to hyperventilate them, you can drop them down to 3.0 very easily, and all of a sudden now you have all sorts of arrhythmias. So you have to think about everything. Okay? You have to understand the mechanisms of what occurs. So that has to do with acid-base disturbances, which then leads to potassium to drop. Okay? On the other hand, if you're not ventilating very well, you're hypoventilating, potassium begins to rise, and you get the other effect. Okay? But usually hyperkalemia slows down the heart, not accelerates it like in hypokalemia. Drugs and also anything that can alter the autonomic nervous system, including pain. Drugs such as catecholamines, which also increases sympathetic drive. Volatile anesthetics also affect the actual conduction velocity through these sympathetic nerves. Most of the time we suppress it, so the only time that's not necessarily true is once you get above a certain MAC value, especially for desferrine, above a MAC of 1, you start getting tachycardia with those drug agents. And sometimes you see that, and unless you remember that, you have to cut back in the agent, not give more of it. You're just chasing your tail. Coexisting cardiac diseases such as prolonged QT interval and pre-excitation syndrome can also become important. The reason I've included this drawing on here for you is that it shows you that the actual coronary vessel is right along the surface of the heart. And that means it has to send in perforating arteries into the myocardial cells to eventually perfuse the inner portion of the heart. The endocardium, which is the most inner portion of the heart, which is here, is the most distant from the blood vessel. The subendocardium, which is the next layer down, which is still pretty far away from the coronary blood flow, is where the conduction fibers are running. Okay? So that should just think it through. If it's pretty far away, one of the earliest signs of ischemia is going to be autonomic or automaticity changes in my electrical activity because it's the most furthest away from blood flow. And that's what the case is. That's why we always have to make you think, hey, look, if I start seeing arrhythmias all of a sudden, I got to make sure that I'm delivering oxygen to the patient. Remember, we talked about this briefly, so I'm going to go through this pretty quick. This is the pacemaker potential, which is phase 4. The phase 4 action potential can be reached threshold much more rapidly with sympathetic nervous system activation versus parasympathetic. The slope actually decreases, slowing down heart rate. So this is the phase 4, and you can see that the slope is increasing here. In this case, it's going flatter. Okay, and that slows down the heart. Again, phase 4 is the critical aspect of what you can actually alter to increase or decrease heart rate. What you can alter this phase 4 is to increase it. You can do anything that causes sympathetic discharge, such as stress or arterial hypoxemia, hypercarbia, catecholamines, such as sympathetic drugs, hypertension and hypothermia, and also acute hypokalemia will more likely lead to significant atrial and ventricular tachydysrhythmias. As for phase 4, decrease of slope is usually parasympathetic activation, which includes vagal stimulation, of course. So anything that causes deep pain. Okay, so when the person pulls on the peritoneum and you get vagal afferent parasympathetic activation, it then leads to the heart rate to begin to decrease. You can actually go in asystole if you pull hard enough on this vagal stimulation. You can also get a change in phase 4 slope by putting more positive pressure in the right atrium. So positive airway pressure or Valsalva maneuvers actually increase the intra-atrial, right ventricular intra-atrial pressures, which then causes this effect. Okay? And then you get also acute hyperkalemia, induces the heart to slow down. Eventually, if you give a high enough dose, it goes into asystole. Now, one of the things that you can look at is arrhythmias. You look at the first thing you want to look at is heart rate. How fast is the thing going? So it's either tachy or brady. Okay? So if it's fast, it's over 100, it's tachy. If it's less than 100, less than 60, it's brady. Okay? Then you want to look at the waveform pattern. You want to make sure there's a normal P wave. Then you want to see the relationship between the P wave and the QRS. We're going to talk about the conduction delays in a second. Then you look at the actual duration of the QRS, which shows you the health of the myocardial cells, plus the health of the His-Purkinje fiber system. And then you look for overall rhythm, and then you see if there's any early cardiac beats. Another way to look at arrhythmias, which is the way I like to look at it, is looking at the initiation of the event. Okay, which means I look at it from the anatomical point of view. Is the arrhythmia originating in the atrium, or is it originating in the ventricle? Which is more serious? Ventricular arrhythmias are much more serious than atrial arrhythmias. Atrial arrhythmias are kind of a nuisance, and they may kill you, but the chances of you dying on it are lower than the ventricular arrhythmias. Ventricular arrhythmias you've got to pay attention to right away because you have a major issue at that point. Okay? If you don't treat it pretty quickly, you're going to have a problem. So you can also have AV node disease, which can also be conducive to very significant blockades like third-degree AV block, which can be very serious as well. Then also, besides looking at the actual anatomical, I look at it as from type. Is it either fast, slow, or absent, which is pretty very serious. You know, asystole is absent. That's not a good thing. Or is it aberrant? Cardiac conduction, normal velocity is going through the SA, going to the AV node, going to the His-Purkinje fibers, and then forms the normal P wave, QRS, T wave complex. The arrhythmias that I want you to know is you need to be able to treat. Okay? The first thing about treatment is correct the problem first. Do not pull out your drugs unless you know what the source is. If you're hyperventilating, stop the hyperventilation. And everything gets better, guess what? You most likely have hypokalemia that's underdiagnosed, and you may consider getting an electrolyte panel to see if your mag level is low as well as your potassium level. Never, never, never draw just a potassium level. It's a waste of time. Okay, because what you'll do is you'll make the mistake of assuming that the magnesium is absolutely fine, and you'll start pouring in potassium, and you'll notice 6 hours later that the person's still not getting better, and you wonder why. Then somebody will tell you, hey, remember Dr. Nolan said about magnesium? Then you'll draw the magnesium level, find out that it's low, and guess what? You just wasted all that potassium. It's not going anywhere in the cell. It's not going to correct unless you replace it with magnesium first. Okay? So always check your mag with your ionized, potassium. If you have corrected the source of the problem and it still doesn't get better, then you pull out your antiarrhythmic drugs and you start considering which one you're going to use. Okay? If it gets really severe and significant where the person becomes to deteriorate, you need to consider doing electrical cardioversion or artificial cardiac pacemaking. Okay? That includes all the way from non-invasive transcutaneous, which is what we teach you here, and you can occasionally do an invasive cardiac pacing, although the last time I did one was almost 7 years ago. So it shows you that our instance of actually putting in transvenous pacemakers has really gone down since the cardiologists are putting a pacemaker in over any human being that we know of. My personal attitude would be about 2,000 years from now, there'll be a little guy with a little metal detector walking around Naples, and he'll be able to find all the pacemaker batteries that we have in buried people in this town. So there's a lot of pacemakers being put in right now. We're putting in almost 20 pacemakers a day. at times. Just think of that, okay? But that's where it's going. The antiarrhythmics have failed in treatment modality. It actually kills you faster if you have an antiarrhythmic, okay? It works well, okay? The problem is you can't reverse the arrhythmia that it induces. Now, that doesn't mean all antiarrhythmics, but I'm talking about the Cs. The two Cs, the flecainide and encanide. Those are much more dangerous drugs, so be careful if you're using those things, okay? Pacemakers are why it's been replaced. There's indications why we don't put in pacemakers, and depending on the age of the patient and stuff like that. But still, the long-term studies show that it's not a good thing. So this is our friend. Okay, this is a pacemaker. This is how small they are now. They're the size of basically of a silver dollar. They're very lightweight. When I first started, they were the size of a hockey puck. Okay, it was pretty impressive. Okay? The electronics have actually gone down, and most of this is actually not electronics. Most of this is what? Battery. The actual size hasn't come down because of battery size. Until they get a better battery, they're not going to go down any further in size, pretty much. The actual battery life on these is anywhere between 3 to 5 years. Okay? So you can actually use these pacemakers, actually do a cardioversion as well. You can actually interrogate these guys now, and you can actually do a cardioversion without having to do it outside. And sometimes I remind that to the cardiologist because sometimes they forget. You might as well not put electricity through a device if you don't need to. If the device has the capability, try it through the device. It uses a lot less amperage, so you're more likely to get less into trouble with it. Disturbances of the cardiac impulse conduction includes first degree, second degree, third degree, and what's called univesicular blocks. We're going to go through these very quickly because I've already talked about them before. Instead, I'm going to talk to you about what the pathophysiology of these are. First degree block is very common. It's seen especially when you put positive pressure ventilation in people. As the atrium dilates, there's usually a prolongation in the PR interval. It's not significant in the sense that the person's not going to go into third degree block, so this is a benign problem. A second degree AV block called the Mobitz 1, called the Wenke block, is an AV conduction node delay. It's usually the upper portion of the AV nodes is diseased. So this one is also considered benign because you don't lose completely the actual firing mechanism. What you do is you get an increasing widening in the PR interval, eventually where you lose capture. Okay? And then, so the person loses a beat here occasionally. This is not something that is significant in the sense that it tends not to go into type 3. Type 2 is much more serious. And never put anybody to sleep with a type 2 Mobitz. Okay? Mobitz 2 is not a joke because what happens as soon as you put this person on positive pressure ventilation, the PR interval will basically stop completely and you go into complete third degree block. Okay? So this person needs a pacemaker before they come to the operating room. Okay? What you see in a type 2 Mobitz is you don't get any PR interval widening. All you see is just basically loss of signal. The disease is on the lower portion of the AV node, which is the firing component. So the firing pin is diseased in that situation and is more likely to cause problems in the OR. Then you have the conduction blocks. In case we're talking about right and left bundle branch block. The right bundle branch block has rabbit ears in V1. The way you remember it is put the R and flip it. You got a V when you flip an R upside down. Okay, so V1 is going to have the double rabbit ears in it. You're also going to see that a person who has a right bundle branch block does not have a problem if you put in a pacemaker or a PA catheter through them because that, even if you touch the conduction fiber on that side, you're not going to touch the left side and you're not going to have any problems. On the other hand, if you have in lead 1, which is the left bundle branch block with the rabbit ears, and you have a left axis deviation many times with this disease process, you have what's called a left bundle branch block. And left bundle branch block is much more serious in the sense that if you put in a PA catheter in there and you hit the hit the right ventricular septal wall just right, you'll knock out the right bundle. And now you have left and right gone, and now you have asystole in your hands. Very serious condition to be in. Yes? The rabbit ears tend to be consistently more visible in lead 1 for left, and you can also see it in lead V1 in the right. That's the most consistent finding. The axis deviation will rotate by 30 to 50 degrees depending on what your initial axis is at. So sometimes people will still be in the normal axis, although it'll be shifted more towards the left in a left bundle branch block, but they can still fall in the normal axis and be like almost like in lead 1 plane. Okay? So that would be considered still normal. Okay? So unless the person is a little higher and then they go into left bundle, you see in the left axis deviation, that's when you really pick it up. So you can't always be consistent with the left bundle, okay, with the left axis deviation. And the same thing goes for the right. It depends on the initial axis point where that person's at, and then they rotate 40 to 50 degrees when you go into right bundle. The reason you get these axis deviations is because it takes the conduction longer to get through that zone that doesn't have the Purkinje fibers intact. So the signal goes through the fast one first, and the delayed signal then shifts the axis towards the point of injury. Okay? So if you're saying a left bundle branch block, you see the signal rapidly go to the right because it goes through the his Purkinje, but then it swings very late to the left. And that's what gives you the rabbit ears that are wider in lead 1. Okay. If you look at B1, the same thing happens, except you're looking at more the anterior portion because it's a right ventricle. Third degree block is a bad place to be because usually heart rate drops down to 30. If you're really unlucky, you'll lose completely everything and you'll just get P waves with no QRS activation. Most of the time, the heart will sort of throw itself back into mode by giving you PVCs and gets you out of trouble. Okay? My personal opinion is one of the things that I think is very, very dangerous when you're doing a cardioversion is that people get into routines. Okay? And one of the routines that people get in anesthesia is that they give lidocaine before any anesthetic, before propofol. And the reason you're doing that is because you're going to stop the pain from the propofol when you inject it. This is one of those cases where you never do that. Anybody who gets a cardioversion does not need an antiarrhythmic before you do a cardioversion. That's really silly. And I've seen people get into asystole and they wonder why they got there. And I look at them like, dude, you just gave lidocaine. Okay? Now the heart has no reason to restart. Okay? You want to have some ectopy for the heart to restart when it gets shut off. Okay? So don't give lidocaine to these people. Okay? That's underreported, I think, in the literature. Okay? So if you're doing a cardioversion, just make sure you just only Diprovan. You don't make it so they're apneic either, which is a very bad place to be. Instead, just give a little bit of propofol, just enough that they're out, but they're breathing on their own, and then shock them. Okay? And of course, cardioverting them appropriately. We'll talk about that in coexisting. Causes of third degree AV block include primary fibrous degeneration, which is basically old age, lack of oxygen, which is ischemic heart disease, overstretching of the heart, such as in cardiomyopathies, where the heart gets dilated. Inflammation of the heart can also lead to third degree block, so things like ankylosing spondylitis and myocarditis, which are inflammatory, self-induced, because autoimmune diseases can occur. You can also have iatrogenic after cardiac surgery, or from the cardiologist putting a pacer wire through something. Could be also congenital. Increased parasympathetic activity from vagal overstimulation can actually induce complete third degree heart block. And certain drugs as well. The ones that you really have to worry about is reversal agents without giving the appropriate dose of anticholinergic with it. Okay, so you never give neostigmine unless you have the anticholinergic attached to it, which is in this case Robenol. Electrical derangements such as hyperkalemia will also induce a third degree AV block. This is the actual cardiac dysrhythmias I expect you to be able to identify and diagnose. Okay. Sinus tachycardia is the first one. That's the most common. This usually indicates a heart rate more than 100. And it's usually consistent with a nice short PR interval with a nice QRS complex. The most common cause of sinus tachycardia is usually surgical stress. Anything that increases stress levels, such as anxiety, pain, which means it's light anesthetic, fever, and arterial hypoxemia. It could also be from overdosing on too much of a volatile anesthetic. Desferrine is a very common culprit. Once you get above 6.0 on your desferrine, which is that's a MAC value of DES is 6. If you get above that, you start seeing sinus tachycardia occur. And then people start chasing their tail by cranking up the desferrine some more. And they're just shooting themselves in the foot. You're not going to make it better, you're going to actually make it worse. So the downside of using desferrine is you have to use supporting, because of pain control with fentanyl or some form of narcotic. So make sure that you're covering it with enough narcotic to really keep the person comfortable. Okay? The other thing you get sinus tachycardia is from decreased contractility in some situations, such as in congestive heart failure. These are the patients you don't want to slow down too much because then you won't have any ejection out of it. You need to treat the underlying problem first before you start trying to slow down the heart. If you have a patient who is in cardiac tamponade situation, then you don't really want to change things until you get that problem fixed. You can also have sinus tachycardia from decreased preload, which is I guess one of the more reasonable reasons for why we get tachycardia in the operating room. You also have decreased afterload from sepsis. You have increased basal metabolic rate from hyperthyroidism and MH or anything else that would increase the basal metabolic rate. And of course, metabolism from hypoglycemia is something you never see sinus tachycardia in the operating room. Never. You may get sinus tachycardia if somebody is awake, but in the OR, the anesthetics will actually suppress the system enough that you will not pick up sinus tachycardia as being hypoglycemia. And that's a bad thing, because if it's part of your exclusion process, guess what? You're not always going to miss it if you think that you're going to get sinus tachycardia with hypoglycemia. You won't under general anesthesia. Sinus bradycardia is the next one, the next most common. His heart rate's less than 60. You see a normal P wave with a slightly prolonged PR interval most of the time. You don't see any kind of arrhythmias in the sense of losing beats, which is just a slow heart rate. This can actually considerably affect the actual total performance of the heart by dropping the blood pressure significantly, because you're actually dropping the amount of cardiac output. Remember, cardiac output is heart rate times stroke volume. So the stroke volume may be okay, but if the heart rate's too slow, you're not pushing out enough cardiac output. This is the most common reason for putting a pacemaker, and we see this all the time. This is called sick sinus syndrome. The situation when the heart sort of accelerates and then it stops. And it gives you a nice agonal period of time. You can imagine most people are not going to be happy. And this is when people crash and hit the ground and break their hip or break their hand. So one of the things you've got to think of when you're taking care of a hip in the middle of the weekend is the first thing you should ask is, do you remember hitting the ground? You know, if this person looks like they just got the heck beat out of them, you know? They most likely hit the ground at full velocity with nothing and didn't even know what happened until they hit it, okay? Because of what happens, they went unconscious. And that person has sick sinus syndrome, and you put them asleep, you're going to find out the hard way. So get an EKG, put them on telemetry, see how the rhythm is going. If the person's got a bad arrhythmia, the hip comes secondary to the heart, okay? I know that you know what the orthopedic surgeons tell me? Says, what's the heart for? And I said, well, I know what you guys consider the heart for is only because it pumps antibiotics to the bone. But that's really not what the heart does, okay? So, but you got to be careful. The orthopedic surgeon will take anything into the operating room, okay? So make sure that you protect the patient so they don't get harmed by the craziness of trying to get everybody in the operating room fixing their bones. Atrial premature and junctional premature beats. Junctional tachycardia may take place. Usually you see a high junctional, you'll get a normal QRS, but you lose your atrial, and you actually get what's called retrograde P waves as well. So you'll see it inside the T wave sometimes. Then you have PSVT, which is paroxysmal supraventricular tachycardia. There's lots of reasons for PSVT. The most common being atrial fib or atrial flutter. It may also be due to WPW. So you really don't know which one you're dealing with. Okay, so you've got to slow down the heart rate to figure it out. So to properly treat this, do not give calcium channel blockers first. If you do, and this is WPW, you may be in really big trouble. Okay? If you give calcium channel blocker to WPW patients, you may actually get a more rapid supraventricular tachycardia taking place because you knock out the AV node, but you don't take care of the aberrant tract. And that person begins to accelerate even faster. The consequence will be that you go into VTAC or VFib. So don't want to be there. Okay? So the first treatment modality is slow down the heart first. The way I do it is we use adenosine. Okay? You have to get it from the refrigerator because it does not hold well in the cart because it's warm. So you have to get adenosine out of the refrigerator. 6 milligrams IV bolus given through the vein of an arm or in the right atrium or as close to the right atrium as possible. If you inject it through the IV, lift the arm up really quick so the adenosine gets in. Now, the importance of adenosine is a normal metabolic byproduct of metabolism of the heart. It's the way the heart knows that it's in trouble. Okay? If the heart is working too hard, it starts releasing large amounts of adenosine, which acts as a negative feedback inhibitor. Okay? It basically tells the heart, slow down because you're dying. Okay? So most people, when they get an adenosine shock, what are they going to feel like? Like they're dying. Okay? They're not going to like it. Okay? They're going to feel miserable. Okay? You need to tell them, you may vomit, you're not going to like me, but it's going to be temporary. Okay? And the scary thing is when you first give somebody adenosine and you see a 5-second pause without any heart rate, it makes your heart stop. You're like, oh, I just killed this patient, you know? And the good thing is eventually it does come right back. Okay? I have seen adenosine one time be given and the heart did stop. And we had to do chest compressions for about 3 to 4 minutes. So it's not my favorite drug at times, but it is a way to get yourself in and out of trouble pretty quick. The thing that adenosine, the reps tell you, which is a lie, is they tell you that it converts everybody. That's a bunch of BS, okay? Clinically, I've been using this too long. It converts maybe 10% of what you see. It's really a diagnostic tool is what it should be used for. You're basically slowing it down the heart just enough to figure out if you're an atrial fib, atrial flutter, or WPW. If you're an atrial fib, you treat it, okay, with certain drugs. Atrial flutter, you treat it a certain way. And if it's in WPW, then you've got to think about what you're doing, okay? Atrial flutters, if you slow this SPSVT down, you see this. This is a 3-to-1 block. Okay, you get 3 P waves for every 1 firing, so this is pretty fast if you let it accelerate. So this is usually tachydysrhythmic. Okay, usually you'll block the AV node to do this treatment, and hopefully it'll convert. Digoxin is supposedly not able to convert, but the trick to converting any atrial arrhythmia is slowing down the heart rate slow enough that it eventually resets its SA node. So usually it means that you have to get the heart rate down to 60 or less. So most of us will either give digoxin, which is an AV node blocker, and suppresses it. Usually the heart rate will begin to slow down, and then all of a sudden the heart flips. Okay? Or you can give beta blockers to slow down the heart rate, so eventually it flips too into its normal mode. Okay? And if you need to, you can cardiovert these people out of it as well. We do that a lot in the endo centers up here. Atrial fibrillation is much more serious than atrial flutter. Atrial flutter, you'll still have some degree of contraction of the actual atrium, but not very effective. In atrial fib, forget about it. You've lost everything. Okay? So now you'll lose all your A waves, okay, from your CVP as well as from your PA occlusion pressure. The only thing you'll see is a C and a V. Okay, so there'll be no more existence of an A wave. There's no contractile component of the atrium. Okay? Atrial fibrillation can get you into trouble because it's usually induced by hypokalemia. Okay? It's the most common reason for it. So if you replace the potassium, a lot of times these people revert back, and magnesium may also be a critical component of that therapy. Junctional arrhythmia is becoming more serious, depending on how wide the QRS is. If you have a widening junctional arrhythmia, it could cause it to go into a complete third-degree block. So this is a person who may not want to consider taking the operating room. I would have the cardiologist evaluate this patient and before I'm doing anything, and maybe considering putting a pacemaker in. Wandering atrial pacemaker is a situation where the disease process is taking place in the atrium. Instead of the SA node firing properly, it's having competing points in the atrium where they fire in intervals, and as a consequence you get a wandering P wave that can either be antegrade or retrograde. Then you have PVCs, which are much more serious. These are premature occurrence of ventricular contractions. Usually you see an absence of a P wave, and you see a widened QRS, and the ST segment is actually on the opposite side of the QRS. You will also see an inverted T wave, and you can see also compensatory pause. One of the things that you want to do is you want to immediately put a pulse oximeter on this kind of patient so you can see if it's either a conducting or non-conducting PVC. What that basically means is it generating a pressure or not. If the PVC is too close to the T wave, it may not generate a good enough pressure in the heart, so you get a very low, and it won't count. Okay? The other danger, too, is if you get too much PVC closure on the T wave, you get what's called a Q on T phenomena, and then it can go from this to a V-TAC mode or a V-fib mode. So you want to be very careful if you start seeing that the PVCs are getting really close to your T waves. Conditions associated with your PVCs are things like normal heart, believe it or not. I had a patient who was on Bigemini the other day that was 32 years old. I was kind of impressed, and I'm going like, I'm not putting this guy to sleep. And he was having a hernia surgery, and the surgeon said, well, you know, he's fine. I said, no. If he had a cardiologist, no. Okay. Send him to the cardiologist. I'm going to say he's fine, but I just don't like the idea of having to put a 31-year-old to sleep without knowing what is going on. So they did a Holter on him for 24 hours, and sure enough, the guy's been on, actually did it for a week. He was on continuous Bigemini, doing all of his normal activities with nothing. So some people actually walk around and are normal. So much for that. So it could be normal. But the first thing you got to think of is, of course, decreased oxygen delivery. And of course, the guy had a stress test done to him, and it was found to be normal. So you don't want to take this guy back and find out that he's got left main disease. You put him to sleep, and you find out that he goes into complete heart block, and he dies in front of you. Okay? You could also be from inflammation of the heart, from myocarditis. It could be from sympathetic nervous system activation, which occurs quite often from pain. If you're seeing a lot of PVCs and you know your oxygen levels are adequate and your blood pressure is adequate, most likely it's due to pain. If you give a little narcotic, then it all goes away. Okay? You could also be from electrolyte disturbances as hypokalemia and hypomagnesemia. Things like digital toxicities is also seen. I've had these from caffeine myself. One of the things that was interesting about in Chicago was we had Starbucks about every block, and in the hospital there was 2 Starbucks. So I began drinking like 4 Starbucks drinks a day, and all of a sudden I started noticing, hey, my heart's really racing. It's like, what the heck's going on? Put myself on a Holter and found out that I was on by having trigeminy. I said, ooh, what's caused this? And just had to stop the coffee, and it went away. So caffeine can really induce this in some people. Alcohol can also do it as well as cocaine. And you can also have mechanical irritation that affects as well. Hyperkalemic arrest is something you need to understand very well. The way I tell you guys to learn it for sure is when you go to your heart room, when they give the cardioplegic solution to stop the heart, just look at the EKG. You'll see the pattern that will be consistent with hyperkalemic arrest. Okay? The hyperkalemic arrest, of course, can occur from inadvertently giving succinylcholine to somebody who has increased levels of receptors on the muscle. You will see initially a peak T wave, followed by a widening QRS. Eventually, the widening QRS goes into what's called a sinus node pattern, where basically starts generating almost like an S wave, and eventually flattens out into a systole. So you should see that in the heart room. VTAC is the next one that we're going to talk about. VTAC is much more serious. If you're dealing with this, you've got to deal with it pretty quickly. There's 2 forms of VTAC. There's stable and unstable VTAC. The stable VTAC, of course, is the one that has a normal blood pressure or considerable blood pressure over 100. If it's unstable VTAC, means that the heart rate is less than that. Now, be careful with the differences between VTAC. It could be from also somebody tapping on the EKG lead. So look at your pulse oximeter. If your pulse oximeter says 80 heart rate, and this looks like it's going at 140, it could be some surgeon doing this to you or Dr. Nolan, okay, just to see if you're awake. Okay? And trust me, I will do that to you because I think it's important for you to recognize if you're hearing or you're not paying attention. This is the one that's serious. And I can induce a great VFib by tapping it. Okay? So I've gotten to be an expert on this. Okay? And most people, if they're paying attention, their head should swivel up and go like, what the heck's going on? Look at it. And then if you're astute, you'll look at me and go, what are you doing, Dr. Nolan? Okay? And it was really funny. One day I was about to do that, and all of a sudden the person went into VFib. So I wasn't laughing at that point, but the student looked at me and was like, you did that. I said, no, this is real. So he looked at me like, oh. I said, yeah, this is real. We got to start doing something. So we actually just did a cardiac thump, and it got him out of it. So you can generate up to 250 joules with the cardiac thump. And when your really kind of anxiety levels goes up, I think you can generate a little more than that. So my anxiety levels are pretty high at that point. I don't like going into VFib. It's not a good thing. You immediately lose pulse in VFib. You cannot have any form of pulse with VFib. If you have a pulse, you have VTAC. Okay? It's just a barren VTAC. But if you have no pulse, it's VFib until proven otherwise. The only way out of VFib is one way. Defibrillate, defibrillate, defibrillate. And stop ventilating. Immediately, the first thing you do is take your ventilator off. Shut it off. Okay? Do chest compressions and immediately get the electrical and defibrillate first. The reason that I'm telling you to stop ventilating is because ventilation is extremely detrimental to the heart if you want it to turn over. It's been shown many, many years ago, and finally the ACLS has finally come around where they're not ventilating people anymore. Okay? Ventilation is only important if you're not receiving oxygen. Okay? So somebody, which is the other where they went too far, they said that nobody should be ventilated. That's wrong. You should make sure that person's oxygenated. Give them 2 or 3 big deep breaths of 100% oxygen, and then let them be as while you're doing CPR. Your lungs are full of oxygen at that point. There's no more need to start affecting cardiac performance by putting positive pressure ventilation. I used to teach this to residents all the time, which was very interesting. We had A-lines in almost all our patients in the ICU, and every once in a while we'd have somebody go into VFib or something bad, and we would do CPR, and then I would tell the students, okay, the residents, here's how I want you to do it. And I said, forget what ACLS teaches you, and I'm going to teach you how to do it so we can get the patient out of it quickly. So we would teach rapid compressions okay? And watching the A line. The faster you did the compression, the faster the stacking would take place, which is diastolic stacking. And once you got the diastolic stacking to around 50, that's when the heart flipped over, every time, okay? If you couldn't get that diastolic pressure up to 50, game over, okay? Now the problem is, every time you squeeze the bag of ambu and push it air, what happens to the diastolic pressure? 0. So you're back at square one. That's why we said stop ventilating. Don't ventilate until we get the person back. So we do chest compressions. Literally in about a minute, we get most people back. And it's just simply by changing and understanding the hemodynamics that are taking place. Positive pressure is really, really bad for you when you don't have a blood pressure. Okay. Now, reentrant arrhythmias is a last portion of this discussion, I think. No, we got some more to go. Okay, so we have you have your circle phenomena that takes place, like in WPW. You have an accessory pathway. What happens is a normal pathway should go through an AV conduction fiber. And because it is a conduction fiber, like an axon in a way, it only goes in one direction. Okay? But when you have an accessory pathway, it has the ability to go around that point, and it can be either outside or inside. Depending on which one you're looking at, it's Langerhans syndrome or WPW syndrome. Some of them are outside and some of them are inside. The more serious ones, of course, are the ones that are outside. Okay? You can have WPW syndrome, Langerhans-Levine syndrome, Mahin pathway, and prolonged QT interval. The most pathognomonic to this is WPW syndrome. I was always told that you'll never see this in your career, maybe once in your life. I've seen about 30 or 40 of these, so I think somebody was teaching me wrong. And my first diagnosis of this was actually in the OR 2 years out of my residency. I had a young man that was 21 years old that had to go in for an appendix. And you don't do a 21-year-old, you don't get an EKG, especially the guy's got no symptoms and he's actually going to fireman school. So, you know, the guy's pretty much a brute, okay? And he looked like a brute. And so we put him to sleep. As soon as we put him to sleep, he goes into a rapid heart rate, 140 heart rate. The person I was working with, which was an old-timer, said to me, he said, should we give, I want to give some verapamil. I said, no, stop, I don't know what it is. Let's take a look at this more carefully. And I said, you know what, I don't like this. So we didn't have adenosine then, so I gave a little bit of Esmol, something that could be reversed. So we gave a little Esmol, slowed down the heart rate, and all of a sudden we started seeing this. We saw this guy. See that little, what's that look like? That's called a delta wave, okay? There is no PR interval. Why is there no PR interval? Okay, because you have an extra accessory conduction that's actually bypassing the AV node. So the electrical activity is going right to the ventricle. So you're losing that normal PR segment where it's just flat. Instead, the signal goes through and goes into the ventricle right away. So this is the actual EKG of this gentleman. And you can see that you have delta waves all over the place. That was really cool. I actually diagnosed WPW, and that was 2 years out of residency. So, yep.
So the AV node is being bypassed.
Yep. Okay. And if you give verapamil to that person, the AV node shuts off, and what takes over? The accessory pathway takes completely over, and you can get this really rapid reentrant phenomena taking place and going completely into VTAC, VFib. That's very, very difficult to treat. So this is the mechanism, shows the SA node. This is the accessory pathway. Okay. The cool thing is we actually have a lot of EP specialists here. If I told you this 7 years ago, we had 0 EP specialists. Now we have like 5. Okay. Why do we have so many, what's EP? Electrophysiologic cardiologists. Okay. So they're actually specialized just in taking care of this. The reason it's so much evolved in the last few years is because the studies have demonstrated that these antiarrhythmics don't really work. So they've gone to have to ablate the heart. So we actually go in there and burn out this accessory pathway by mapping it, and you actually would deliver the anesthetics to those patients and take care of them. Okay, so you have to understand a little bit of it. You can see in phase 2 here, that's the aberrant pathway, which is here. This is aberrant pathway here, is what generates a delta wave. As soon as you ablate it, that PR interval goes back flat. It's pretty cool when you see it, and it means you really got it. Okay, famous person who has WPW syndrome. Okay, he's one of my favorite guys. So. Anyway, never treat with verapamil. If you do that, you're going to get into reentrant rearrhythmia. Okay, then you get yourself in a lot of trouble. That's a key point. Then you got Longanong-Levine syndrome. It also generates a delta wave. It's not as significant as WPW because it tends to be inside the intraventricular sheath, in the AV sheath. So it's still an aberrant pathway, but it's not as severe as the WPW syndrome. The prolonged QT interval is significant in the sense that if you give too fast certain drugs, which in this case was blamed on Zofran, but really the Zofran dosing that we're giving is a joke. Okay? So it's not a problem for our dosing. If you give 120 milligrams of Zofran, which is what they do in the chemotherapy realm, yeah, that can cause problems. Okay? You can prolong the QT. And the reason it's such a dangerous thing is because you prolong the QT, what is the QT going to do? It's going to fall on the next QRS. Okay, so it's a Q on T wave. So that means you're going to go into VTAC. So that's something you don't want to see. But with us giving 4 milligrams, it doesn't really matter. The drug reps were really pushing this real hard and saying Zofran was very dangerous, and it's not. Okay, Enzamet does the same thing if you give it in high enough doses. If you give any of our anti-nausea drugs in high enough doses, it will cause a prolonged QT interval. Even the dopaminergics will do that. So be careful. I personally like Zofran. It's pretty much taken over the market because it is a better drug. So.